Welcome to this video conference coverage from the 2024 American Society of Clinical Oncology annual meeting in Chicago, Illinois, and the European Hematology Association Hybrid Congress in Madrid, Spain. In this series of 5 episodes, our expert hematologists, oncologists, Dr. Saira Ahmed and LaCasce will review the most recent data for the treatment of patients with non-Hodgkin's lymphoma, including diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, chronic lymphocytic leukemia, and an overview of the hot topics in the field. Stay tuned until the end of the program, where Dr. John Winters from New England Cancer Specialists joins us for a discussion about how these data may impact community hematology-oncology practice.
Hi, I'm Dr. Saira Ahmed from MD Anderson Cancer Center, and today I will be discussing the data presented at ASCO and EHA for the treatment of diffuse large B-cell lymphoma. So let's first discuss frontline therapy for the treatment of patients with diffuse large B-cell lymphoma. So the frontline combinations are with R-CHOP, CHOP, or POLA-R-CHP, and we have 3 different novel agents that we'll be discussing. One is golcadomide, which is a novel small molecule cell mod that co-opts cereblon to induce targeted degradation of the transcription factors, Ikaros and Alos, epcoritamab, the CD3/CD20 bispecific agent, and tucadinestat, which is a histone deacetylase inhibitor. In the phase 1b study, golcadomide at the 0.4 milligram dose in combination with R-CHOP demonstrated a very manageable safety profile, and the addition of golcadomide to R-CHOP did not compromise curative treatment. This was an open-label, multi-center dose escalation trial with adult patients, and there were 3 different dose levels. The primary endpoint was safety, but efficacy was a secondary endpoint. And in fact, what it demonstrated was that it had a complete metabolic rate of about 89% at dose level 1, and it was similar in patients that were either GCB or non-GCB subtype. And to date, the median duration of response has not yet been reached. So there are data here to support the initiation of a phase 3 goal-seek clinical trial of golcadomide plus R-CHOP versus R-CHOP alone in frontline therapy for patients with high-risk diffuse large B-cell lymphoma. The toxicities were mainly hematologic, as were expected, and we did see patients have febrile neutropenia, although it did not seem to be significant in terms of further infection. The other combination that we will be talking about is the subcutaneous epcoritamab plus POLA-R-CHP. This was the EPCOR NHL study, which was a phase 1b/2, and these treated adult patients in the frontline setting. It showed a very high overall response rate and complete response rate. It is a ongoing multi-arm open-label global study. The 27 response evaluable patients had an overall response rate of 100%, with 89% of patients achieving a complete metabolic response, and the duration of CR has not yet been reached. MRD negativity was achieved early and sustained throughout treatment in the majority of patients with complete response. Interestingly, there was CRS mitigation with the addition of prednisone or dexamethasone, which did seem to mitigate some of the CRS in this patient population. In the phase 3 trial of tucadinestat plus R-CHOP versus R-CHOP alone, what the study interim analysis showed that the 24-month event-free survival for patients who were treatment naive and received both agents, tucadinestat plus R-CHOP, the event-free survival was 58.9% in comparison for 46.2% in the R-CHOP group. Now remember, this is a very high-risk group of patients with double expressor lymphoma, and they had to have overexpression of both MYC and BCL2. The patients received tucadinestat as an oral agent or placebo, and it was administered with breakfast on days 1, 4, 8, and 11 in a 21-day cycle, with the primary efficacy checked at 6 cycles. After cycle 6, patients who had a complete response could continue on tucadinestat. So this does show some improvement over baseline. I think what is going to be interesting moving forward, as you can see in the trials that we highlighted, the backbone in terms of quote-unquote standard of care has changed somewhat. So some trials are still utilizing R-CHOP as the control group, while other trials have moved on to Pola-R-CHP as their backbone of standard of care treatment. And I think this will continue to be something that we will have to address in future trials. Next, we're going to talk about immunotherapy maintenance in high-risk, high-grade diffuse large B-cell lymphoma. In the phase 2 HOVON 151 study, atezolizumab consolidation therapy demonstrated a 2-year disease-free survival of 88% for patients with high-risk diffuse large B-cell lymphoma. Again, this was adult patients with an IPI of 3 or higher who had attained a complete metabolic response after 6 to 8 cycles of R-CHOP. These patients then received maintenance therapy every 21 days for 18 cycles or until disease progression. In the phase 2 study, nivolumab consolidation for high-grade B-cell lymphoma after complete metabolic response for patients who received dose-adjusted R-EPOCH demonstrated high disease-free survival rates of 92% and overall survival rates of 97%. It also was quite safe in terms of side effects. There were immune-mediated reactions, most of which were thyroid. These studies do suggest that there's a role for immunotherapy maintenance for patients after receiving standard of care therapy in the frontline setting, although these patients will experience some degree of immunotherapy toxicity, and the long-term side effects of that are not well known. So let's focus on patients with relapsed refractory diffuse large B-cell lymphoma. Some of the most exciting data has come out of bispecific therapy, bispecific T-cell engagers that are directed towards CD20. There are 2 agents that are now available commercially in the United States. One is epcoritamab and the other is glofitamab. The phase 2 EPCOR study with a 2.5-year follow-up showed that patients with epcoritamab monotherapy had an overall response rate of 63%, a complete response rate of 40% in large B-cell lymphoma, and an overall response rate of 61% and CR rate of 39% in high-grade lymphoma by an independent review committee. Again, these patients were treated with at least 2 prior systemic therapies and received subcutaneous epcoritamab at step-up dosing in 28-day cycles. These patients did experience CRS, about 51% for all grades. High-grade CRS was quite low, less than 8%, and that was, again, with full-dose therapy. In the phase 1-2 study for EPCOR with R-DAX, treatment of patients who were transplant eligible with high-risk diffuse large B-cell lymphoma, the overall response rate was 78% with a complete response rate of 55%. Again, this was given with step-up dosing, and if patients deferred high-dose therapy followed by autologous stem cell consolidation, they could continue on epcoritamab until disease progression. The median time to complete response was 1.7 months, and the median duration of complete response was 13.3 months. In the phase 3 STARGLOW study, glofitamab plus gemcitabine and oxaliplatin demonstrated statistically significant and clinically meaningful benefit in overall survival, progression-free survival, and complete response rates over R-GemOx in transplant-ineligible patients with diffuse large B-cell lymphoma. At primary analysis, there was a significant overall survival benefit with the glofit GemOx versus R-GemOx, with a significant p-value of 0.011. At median follow-up of 11.3 months, median overall survival was not reached for the glofit GemOx group versus 9 months for the R-GemOx group. There was a significant benefit for the bispecific plus chemotherapy combination, which was observed with both progression-free survival as well as complete response rate of 50 versus 22%. The most common side effects were hematologic, and again, there were some patients who experienced febrile neutropenia. Next, we'll be talking about antibody drug conjugate therapy, brentuximab vedotin, which is an anti-CD30 antibody conjugated to an antimicrotubule agent, MMAE. and zilovertamab vedotin, which is an anti-tumor associated antigen TEA receptor, tyrosine kinase linked orphan receptor, ROR1, conjugated to anti-MMAE. In the phase 1/2 HOVON 136 study, BVR-DAP was found to be feasible and effective as a pre-transplant salvage regimen for CD30 positive diffuse large B-cell lymphoma, with a complete metabolic response of 47%. Adult patients were allowed on trial, and they could have either CD30 positive diffuse large B-cell lymphoma, which was categorized as anything more than 1% CD30 positive, or patients who had primary mediastinal B-cell lymphoma after frontline R-CHOP therapy. Patients had induction treatment, which was 3 cycles of BV plus RDAP, and BV was administered on day 1 of each cycle. Growth factor was required after each cycle. After 3 cycles, patients achieving a complete metabolic response or a good partial response were allowed to proceed on to receive consolidation with high-dose chemotherapy followed by autologous stem cell transplant. The complete metabolic response was 53% for primary refractory disease and 38% of relapsed disease. The 18-month progression-free survival overall was 48%, again 39% for primary refractory and 75% for relapsed patients, with an 18-month overall survival of 75%. Toxicity was mainly hematologic, which was something that was predicted. In the phase 3 Echelon 3 study, adding brentuximab vedotin to lenalidomide and rituximab provided improvement in PFS and overall survival among patients with relapsed and refractory diffuse large B-cell lymphoma who were either ineligible for transplant or relapsed after transplant or CAR T-cell therapy. This triplet regimen is a novel treatment option for patients who are heavily pretreated. And this particular trial allowed patients to come on trial regardless of their CD30 expression. At median follow-up of 16.4 months, the median overall survival, which was the primary endpoint, was 13.8 months with BV plus R2 versus 8.5 months for R2 alone. In the updated analysis of the phase 2 trial Waveline 004 zilovertamab vedotin for adult patients with relapsed refractory diffuse large B-cell lymphoma, this trial demonstrated a manageable safety profile with clinically meaningful anti-tumor activity in patients who are ineligible for transplant and or CAR T-cell therapy. Patients had to have 2 prior lines of therapy, including an alkylating agent, anthracycline, and anti-CD20 antibody, and they also had to be ineligible for transplant or CAR T-cell therapy. They received zilovertamab vedotin every 3 weeks until disease progression, unacceptable toxicity, or withdrawal from trial. The overall response rate was 29%, with the majority of patients attaining either a complete response or partial response, with an overall activity of 42%. Next, we're going to talk about treatment with CAR T-cell therapy. We're going to talk about lisocabtagene maraleucel and balacabtagene autoleucel. In the phase 2 study, balacel demonstrated high objective response rate with durable responses. This data showed a low incidence of grade 3 or higher cytokine release syndrome, but also markedly lower rate of neurological events compared to other CAR T-cell products. 73 patients were included in the efficacy analysis. The overall response rate was 75.3% with a complete response rate of 67.1%. Again, the inclusion criteria were adult patients with either relapsed refractory large B-cell lymphoma, which could include diffuse large B-cell lymphoma, high-grade B-cell lymphoma, primary mediastinal B-cell lymphoma, or follicular 3B. The most common subtype was DLBCL. And the median PFS was 5.5 months with a 1-year PFS of 39%. CRS occurred, any grade CRS occurred in 57%, and grade 3 CRS was about 9 to 10%, with only 3.8% of patients having more than grade 3 neurologic events. The phase 3 Transform study also was updated with 3-year follow-up with a median follow-up of 33.9 months. Liso-cel has already been approved as second-line treatment in patients with primary refractory or early relapsed LBCL. And this data demonstrated the deepening of response and continued improvement in efficacy endpoints over standard of care treatment, confirming the benefit, the ongoing benefit of liso-cel. Just to remind us, this was liso-cel versus standard of care in second-line patients, which included a combination of salvage chemotherapy followed by autologous stem cell consolidation in patients aged less than 75 years. And in order to be eligible for trial, they had to have disease that relapsed within 12 months of frontline therapy, or was primary refractory, or ineligible for autologous stem cell transplant, which was a different arm of the study. After a median follow-up of 33.9 months, median EFS and PFS were longer, with a complete response rate and overall response rate that were higher than reported before. Duration of response was also longer in comparison to standard of care. Rates of severe CRS and neurologic toxicity were low, with no grade 4 or 5 events. And the update of second primary malignancy was similar to liso-cel and standard of care arms, with no T-cell malignancy reported. Richter's transformation is a particularly difficult patient population to treat. And the analysis of liso-cel in a real-world patient cohort with Richter transformation demonstrated that there was low incidence of grade 3 or higher CRS or neurologic toxicity. And at a median follow-up of 12.3 months, the overall response rate was 76% among evaluable patients and 66 patients in complete response. The median time to first response was 1.1 month. The median duration of response was not reached, with a 12-month duration of response of 77%, and the median PFS and median OS were also not reached, with an estimated 12-month PFS of 54% or a 12-month overall survival of 67%. The CRS and neurotoxicity was similar to both pivotal trials and other real-world analyses, and interestingly, this is a treatment paradigm which potentially would provide a much better therapy for patients with Richter transformation than we currently have. A prospective multi-center expanded access protocol study with patients who were to receive commercial liso-cel but were then treated on a non-conforming product trial with relapsed and refractory LBCL were also presented. 118 patients were efficacy evaluable, and the overall response rate was 71%, with a complete response rate of 53% and a partial response rate of 19%. In the total population, cytokine release syndrome was reported in 42% of patients, and neurotoxicity, prolonged cytopenia, infections were all similar to the pivotal trials and other real-world analyses. Now, these patients were expected to receive commercial liso-cel, but due to a non-conforming product went onto this trial. And this has often been a question if those products lead to similar outcomes as the commercial product the patient was intended for. Based on this data, it appears that patients can derive clinical benefit receiving a non-conforming product without any increased safety concerns. Now that we're all up to speed on the most recently presented diffuse large B-cell treatment data, let's talk to Dr. John Winters, a community hematologist from New England Cancer Specialists.
Thank you, Dr. Ahmed, and that was a great review of recent data. I do have a couple of questions. So in the first-line setting, we have relied on R-CHOP and POLA-R-CHP, but we now are seeing the addition of other targeted agents with different mechanisms of action, like the CELMoD and the golcadomide, and the potential for IO consolidation maintenance therapy. How do you anticipate approval of these agents to affect how the individual first-line therapy is given?
So I think historically we have seen a number of agents added to R-CHOP or an R-CHOP-like backbone, and traditionally they look great in phase 2 trials, and then when they come out in the phase 3 setting, we don't necessarily have quite as good outcomes. Of all of the agents that we have talked about, I do feel golcadomide seems to have very good data, and I would expect that, potentially would attain approval. In terms of the immunotherapy consolidation, it looks like really nice data, but I think, again, when we put that into a phase 3 setting, I'm not sure how many patients are going to be able to tolerate the full maintenance, are not going to have potentially immunotherapy-related side effects. And particularly now when we have more efficacious frontline therapies, that may not be a strategy that patients would want to have in terms of just a longer duration of therapy. So the field is moving quite quickly, and I think that potentially the addition of novel agents as well as the addition of bispecifics in the frontline setting is going to really change what we consider our normal standard of care therapy for diffuse large B-cell lymphoma.
Yeah, I agree. Really exciting to see some of those responses, with golcadomide and other, novel agents. So we're also seeing some great follow-up data on the liso-cel and diffuse large B-cell lymphoma, as well as data showing the possibility of moving CAR T therapy to earlier lines. When should community, hematologists and oncologists begin having the conversation about CAR T with patients with diffuse large B-cell?
So I think that's a really interesting question, right? Because not only are we seeing improved outcomes for patients who receive CAR T-cell therapy in the second-line setting, there are now clinical trials for patients to receive CAR T in the frontline setting. And oftentimes when you see a patient with a new diagnosis, we talk about, okay, this is what we're going to do up front. And a natural question those patients ask, what do I do if this comes back? And so I think that's probably a pretty good segue to say, even if, God forbid, your lymphoma returns, we still have curative intent treatments. And one of them that we are kind of thinking about and has demonstrated an overall survival benefit is CAR T-cell therapy. When we look at the number of patients that receive CAR T-cell therapy in comparison to those that are actually eligible for CAR, it's only about 15% of patients really get to CAR. And I think part of that is absolutely accessibility, but part of that is making sure that we have good ways for community oncologists to refer patients quickly so that they can get in to get treatment in a timely fashion without a lot of delays. And 100% it's planning for the future that can potentially help alleviate some of those challenges.
Yeah, I totally agree. There's some barriers to getting people to CAR T, even if you're thinking about it in the community, and some of them are going to be more challenging than others, obviously. Do you think there's capacity to do this second line, say for most patients, if it were to come to pass that were, the new guideline or recommendation?
So I think if you asked purely from a infrastructure question, we do not have the infrastructure to treat every patient in the second line setting with cellular therapy. But that was also true for autologous transplant. If you look at the number of patients who are eligible for transplant, and even today still are for, allogeneic for leukemia, et cetera, versus the number that actually get to transplant, it's quite a modest percentage. I think that moving to the outpatient setting, using drugs and products with a better toxicity profile, our standard of care mitigation of toxicity has also improved. And so those outcomes have gotten better. I think all of those particular interventions can increase our capacity. But at the end of the day, we are still requiring patients to pick up and move for 30 days to receive this therapy, which is a tremendous financial and social stress, let alone the medical stress and the side effects and complications associated with this treatment. And unfortunately, we do not have the social system and infrastructure to get these patients where they need to go, nor do we have the ability to build that infrastructure geographically so that every patient is close to a CAR center. So I know the problems. I don't necessarily know the answers to those problems. But I think that there are a lot of different folks who are trying to improve access. And we have to, because this is, again, it leads to a better overall survival. And that's exactly what we want for our patients.
Yeah, absolutely. Are you finding that community oncologists that refer to you are thinking about CAR, or thinking about, often these patients need bridging therapy to get to CAR, and, omitting drugs like bendamustine that might reduce the response to CAR T? Are you finding that that's an issue, or, do you have any advice on that?
So we have a really robust collaboration with our community oncologists, and oftentimes they'll call or text and say, I have this patient that I'm going to refer, but they need treatment now. What would you suggest? And so that is extremely helpful in terms of us being able to say, you please try to avoid bendamustine, or potentially, we can get this patient in ASAP to get this process started. You don't have to wait. A lot of the collective understanding of CAR comes from a baseline of stem cell transplant therapy, right? And stem cell transplant, the conventional wisdom is give a cycle or two of salvage and then send them to your transplant center. And that's just not the way that we have the workflow for CAR, or that we want that workflow to be ideally. And so it has been both educating our collaborators as well as making it easier. Academic institutions are difficult to get in, and even smaller institutions that have CAR T-cell therapy programs, we like to have all of our data first and then have the patient come in. And oftentimes that's not possible for CAR. We need to get those patients in very quickly. And so we've also had to flex and change the way in which we bring these patients in, knowing that time is of the essence. And we don't have that luxury of kind of waiting 3 or 4 weeks before we get that patient in. John, thank you for joining me today.
Thank you so much for having me.
Please remember to take the post-test and fill out the CME evaluation. Please watch the other ASCO EHA conference coverage videos where I discuss the latest data for the treatment of follicular lymphoma, and my colleague Dr. LaCasce reviews treatment of mantle cell lymphoma, chronic lymphocytic leukemia, and other hematologic malignancies. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com.